Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with blocked earwax in both ears, and we are just starting off with their left ear. Now, the patient had admitted to using cotton buds, or Q-tips as they're often referred to in America, and they should actually know better because they are an audiology trainee student, and they have actually been in the past with for the same reason they've impacted wax. So the patient's aware it's not the right thing to do, and hopefully this will be the last time. But they've really lodged the wax deep in their ear, and it's their right ear that was the worst ear out of the two, actually. And in the right ear, they have grazed their ear canal a bit, and I'll just show you that when we get to that, yeah? So I'm just using a full zone suction probe at the moment. The fine end wasn't powerful enough for this, and I'm just detaching it off the posterior canal wall, so the back part of the ear canal, quite adjacent to the eardrum. So you can probably see some of the cotton wool fibres there from the Q-tip, from the cotton bud. And I've managed to remove this, and there's just a couple of pieces of wax, dry skin embedded on the drum, and also some dead skin here posteriorly. I wasn't able to remove the dead skin from the back part of the ear canal. It wasn't significant, it wasn't affecting the hearing, but it was clarinetting. So clarinetting is when you sometimes suction dead skin, the skin can violently flap at the tip of the sucker, and that flapping effect, it's almost like a fly constantly flapping their wings as fast as they can, an insect or a fly doing that, and it lets off a very loud high frequency squeal, and it's not only loud for the patient but it's also loud for myself. So I've decided to just leave that as it was clarinetting. I think I'm going to try and go around it. Let's see. Or I went back to see if I can get it once more. I think I stopped in a minute because it was just clarinetting. So what I'm going to do is just go for this little piece of skin. And again, this is just caused by the patient poking in their ears and pushing it right up against the eardrum. So I'm just peeling it down and away. See, it's quite embedded. Now, often a bit of skin like this wouldn't affect their hearing, but the patient was tolerant, so we couldn't sometimes leave. Sometimes it can. It does vary. Sometimes some patients can notice this, some others don't. Typically they wouldn't. The patient's really still, so I just decided to get that off. You can see that's come away. And now this is their right ear, and this ear was a bit more inflamed, and as soon as I went in, there was a bit of fogging, misting, so that means the temperature of the ear is increased. So the increased heat, it condenses on the lens. So I had to keep the endoscope in there for a bit just to the lens warm up. But on the right, you can see the ear is a bit tender, just here where I put an arrow. So, I did ask the patient if they've got an itchy ear, and that's why they're scratching it. But they said it's more habit, and that's what. So it's probably it's like the firm old debate: what came first, the chicken or the egg? Now, same with that. Did that itchiness and irritation come from the fact that they've been poking in their ears, or is that the reason why they were poking in their ears in the first place? So I've just recommended some over-the-counter spray. If it doesn't resolve, then we'll write to their GP who can prescribe some antibiotic spray and some anti-inflammatory steroid spray. It's all in one, it's combined, and that will help. But if possible, we'll try and treat that without any antibiotics or steroid treatment. So I've just put some oil in there. This was really impacted, and what made this ear a bit more tricky is it's how narrow the ear canal was, because it was a bit inflamed, more laterally though, and you'll see the instrument in a moment. So it's a bit blurry because the oil's in there, and I'm just sucking out some of the excess fluid, but the instrument just about fits in the ear canal. There's very little leeway. I'm just sucking out the oil still. And I think I'm going to revert to a fine end now, we shall see. And the difficulty here is because the wax is right up against the eardrum, if you put too much force, it's going to push the wax up against the drum even further, and the patient will feel it. So you just got to be patient. You got to find the weak spot. Sometimes you go from the bottom, sometimes you go from the top. Typically, you normally have to go from the bottom, and that's because our ears have a dip at the base of the ear canal near the eardrum. It's called the inferior recess. And we've also got a little alcove to the right-hand side of the ear canal, the front part of the ear. And you normally have to, when you get wax that's been pushed in, it gets lodged in the inferior and anterior recess. So you have to lift the wax plug out of the trench. So you can see that I'm trying to do that here. I'm trying to go from the bottom and lift it up and away. And eventually that's the way I removed it. I did try and remove it from the roof of from the top part of the eardrum, but it just wasn't budging. So I've just come away actually. There's a piece of skin that I saw here and I thought, well, let's try and peel this away. And sometimes, miraculously, when you peel this away, the whole skin and wax on the eardrum can also be peeled away in one piece. But so I was getting a bit hopeful at this stage, but my hopes were soon dashed, and you'll see this just peels away. So it wasn't attached to the main plug. So I'm just going to have to go back in and try again. The patient was really still, so it was great. You know, this sometimes can be difficult to tolerate because we're right up against the eardrum. So again, I'm just going from the bottom, trying to lift it up and away. But it was hard to get a suction grip, despite the fact that I put loads of drops in. Now, I can't really use any other instrument. You can't use forceps here because the tip of the forceps will just push this further up against the drum, and nothing there really for me to grab onto and grasp with the forceps. A hook, ear hook, is going to be uncomfortable because you'll be making contact with the patient's bony part of the ear canal and also the eardrum most likely there. And so you can't get anything in and behind, so I've just got to persevere with the suction here. So I've just reverted back to the full sucker, and you can see just the size difference and how much limited space that I've got. I'm going to get it from the bottom and lift it up and away. The secret is here with the sucker is not to come away too quick. So sometimes, and I'm guilty of it, you get a bit excited and think, oh, this is going to come away, and you just come away too quickly with the sucker, and by doing so you lose the suction grip. So you just got to be patient, and I'm quite literally just making the most minimal contact with the embedded wax and skin. I'm just hovering over the surface just enough to elicit a suction grip, and it was moving. But the lens just got slightly blurry with all the oil, so I've just gone out and come back in. And you can see with the sucker, as I introduce the sucker, the ear canal just closes upon itself near the entrance. So that's all the edema, the swelling. So you can see I've hardly got a grip here. I've got the faintest grip, but I'm just tugging this up and away. I'm out of the inferior recess, and now I've managed to dislodge the wax plug. Again, it's just all the oil. So I've just left the sucker still momentarily whilst the oil gets suctioned up because it was getting a bit too blurry there. So you just keep everything really still in the ear whilst that's happening because you don't want to make false moves with the sucker. There we are, that's the patient's eardrum, nice and healthy. You can see it's the inferior recess to trench at the bottom and anteriorly. And you can see as soon as I introduced the sucker there, just on that point there, you can see it flexed. The swelling was, the ear canal contracted almost with all the fluid. Well, I hope you enjoyed that video, guys. And remember, nothing smaller than your elbow in your ear. Take care, bye.